guys, this is Dr. Charity Stanley, and today we are talking about musculoskeletal and connective tissue disorders. So these disorders can be very detrimental to a patient's life. The connective tissue is all throughout the body. So depending upon where the connective tissue is damaged at is going to be where we're having the problems and what kinds of symptoms that the patient is having. So one of the first ones that we're going to talk about is called scleroderma. Within the condition of scleroderma, the skin tightens to the point that it is very difficult for the patient to be able to eat appropriately. This is a picture. The picture on the left is of this young woman with scleroderma. And the picture on the right is of the same young woman before scleroderma started hardening her skin. So what this does, it tightens all the connective tissue within the body. And so it creates hardening of the skin. The skin doesn't stretch like it usually does. So their mouth is restricted on opening. The excess collagen and different skin and different tissues, they have problems with it as well. And the collagen is everywhere. It's within the different organs. So this hardening of the connective tissue can damage blood vessels, can damage the synovium, skeletal muscles, and also internal organs. So what happens with this is we have very fibrotic, degenerative changes that happen, and it causes problems in movement in the joints and can create problems within different organ systems, depending upon exactly how much collagen is present within the organ. So right now, they are looking at improving the diagnostic criteria, and current diagnostic criteria include evaluation of a bunch of different factors, specifically 23 different items. So pathophysiology, what happens to cause scleroderma? Scleroderma creates changes in the skin and internal organs, and this causes systematic and systemic sclerosis that's caused by overproduction of collagen by the fibroblast. We really don't know what causes scleroderma to start, but once it starts, it's very difficult for us to be able to treat successfully, and it's very difficult to get it to go completely into remission. So scleroderma and systemic sclerosis, it affects women 3 to 4 times more often than it does men. So we have different subtypes. The first subtype is diffuse scleroderma. This is a rapidly progressive, generalized skin thickening of the proximal and distal extremities and trunk. So with this type of scleroderma, diffuse scleroderma, we have early involvement of the organs. So that means the organs end up damaged more over the long period. Next type is limited scleroderma. With limited scleroderma, the skin thickening is limited, hence the name, to the distal extremities and the face. Third type is localized scleroderma. And with localized scleroderma, it's a specific area. Usually it will be the face only or the distal extremities only. It doesn't include organ involvement. And these scleroderma tends to overlap, and patients will often have other connective tissue disorders diagnosed concurrently with the scleroderma. With scleroderma, patients have something called CREST syndrome. CREST is an acronym that stands for calcinosis, that's calcium deposits of the subcutaneous tissue, and the periarticular tissue, that would be the tissue that's around the joints. So as these tissues calcify, calcium makes things really hard. And so with the calcium deposition within the tissues, joints aren't able to move as well as they should. And the decreased movement has another effect of allowing more tightening to occur. The RN crest stands for Raynaud's phenomenon, which we've talked about before, where the very distal parts of the fingers will lose circulation and the tissue can turn completely white or cyanotic. Esophageal dysmobility is the E in crest, so they're having problems with swallowing. Sclerodactyly, this is a shiny, tight appearance, and it looks like the skin is starting to atrophy on the fingers or toes. And then the last is telangiectasia. Okay, telangiectasia is another aspect of scleroderma. So we can have different patches of skin that is tight, and it can be morphed into different shapes of the patches of skin that are affected. So scattered patches of skin can be several centimeters wide, and it may have a purple border as a result of the increased collagen within the area. Can also appear as streaks and have linear abrasions. Generally, with this localized scleroderma, no visceral involvement happens. Skin problems with scleroderma. Often we have bilateral symmetrical swelling of the hands and sometimes of the feet. After the swelling, the skin becomes very hard and thick, and it becomes more rigid due to the calcium deposits. So it's more difficult to move the skin. Frequently, the fingers, the dorsal part of the hand, the neck, face, and trunk are all involved. So normal landmarks in the skin, like the skin folds, are absent because the skin is so tight. We may have increased or decreased skin pigmentation in certain areas. So the skin will have like a salt and pepper look to the skin. The skin changes may get better, but will never completely go away, but after several years. We're going to have areas of calcinosis, and then our mouth, the patient's mouth is going to be smaller due to the increased collagen around the skin of the mouth. Stomach problems, GI tract problems, we're going to have esophageal dysmotility. This results in reflux and dysphagia. Can have distal esophageal dilatation and esophagitis. Barrett's metaplasia. This may predispose the patient to developing adenocarcinoma of the esophagus. Duodenal atrophy and dilation may cause postprandial abdominal pain, malabsorption syndromes, diarrhea, and abdominal distension. The colon will start to slow down with its movements, and so bowel movements will become less frequent, and it often results in constipation. And the constipation, it kind of becomes a constant problem that people with scleroderma have. Muscles, their musculoskeletal problems, they're going to have joint pain, polyarthrias, large and small joints are both affected, carpal tunnel syndrome, flexion contractures, and the muscles will start to atrophy. Cardiac problems from scleroderma. You can have left ventricular dysfunction and heart failure. Also, you can have different atrial and ventricular arrhythmias as a result of the collagen invading the electrical system of the heart. So also, as the lungs get involved, and we'll talk about what happens in the lungs here in a minute, as the lungs get involved, the right ventricle of the heart also gets involved. And so frequently you'll have right ventricular involvement secondary to pulmonary disease. When your lungs get involved, you end up with interstitial fibrosis and a very restrictive lung disease and potentially have pulmonary hypertension. Kidneys, scleroderma renal crisis. This causes malignant hypertension that happens quickly with encephalopathy. So how do we diagnose scleroderma? There's several different tests that we'll be doing to diagnose scleroderma. A listing of all of them are on the PowerPoint slide. So the CBC and ESR, your SED rate, is going to generally be normal. Your RF factor will be positive in about 30% of patients. ANA will be positive, and it will show a speckled or nuclear pattern. Anti-sclerodermal antibody, SCL70, is positive in cases where just the skin's involved. Anti-centromere antibody is highly specific for cutaneous disease. There's a lot of other antibodies that are involved that we're really not going to go into. But if we use X-ray, we can see changes within the hands and wrist. We're going to see osteopenia. That means we don't have enough osteocytes within the bones. So the bones are weakening, the muscles are atrophying. We can see with a barium swallow esophageal dysphagia and dysmotility. Pulmonary function testing is going to show us that our patients aren't getting the air that they need. They are having a decreased diffusion capacity and vital capacity, and you'll need a CT to be able to evaluate for pulmonary fibrosis. Endoscopy. We will often do endoscopic studies, and we'll do a biopsy for a specific type of cancer that's associated with scleroderma. It's called Barrett metaplasia. Pharmacologic treatments. Maybe using calcium channel blockers, losartan, angioreceptor blockers, ARBs, or sildenafil, Viagra, for more severe cases of Raynaud's phenomenon. Sometimes we'll be using nitroglycerin ointment or prazosin. They has been shown to have a moderate effect, but it can't cause dizziness, headache, and lack of energy. Prazosin is a very potent blood pressure medication. And so all of those side effects make complete sense. May also be using non-steroidal anti-inflammatory drugs or other analgesics for problems with the joints and for painful calcinosis. Antibiotics may be required because of bacterial overgrowth and due to secondary skin ulcerations due to the skin being so tight. May need proton pump inhibitors or Protonix or omeprazole for gastric reflux. Antihypertensive agents. So we may use those in a high dose angiotensin and converting enzyme inhibitor, such as enalapril. Bronchodilators may be required depending on the pulmonary involvement. And for Raynaud's phenomenon, you can use a topical L-arginine cream. And this stimulates the formation of nitric oxide, which acts as a vasodilator. And yes, this is the same nitric oxide that they use in dental procedures. This is also known as laughing gas. Your body makes its own. And severe symptoms of tightening may respond to injections of Botox. How do we take care of this skin? So we want to maintain moisture within the skin. So we're going to be making sure that we use lotion on these patients. For patients with Raynaud phenomenon, we want to keep them in a warmer area. These people are always freezing. Want to make sure that they are appropriately dressed for the conditions. They may need to wear or have gloves with them or heavy socks with them at all times, depending on the weather and the environment that they're in. They need to avoid handling cold and frozen items without gloves, avoiding exposure to cold winter winds and cold weather. Use of hand and foot warmers. You can actually order these on Amazon. They come in a pack of like 10. You bend a little metal disc that is in the center of this fluid, and it produces heat. So these are reusable, and you can actually boil them and then use them again. Make sure that your patient knows the risk and how smoking is going to make Raynaud's worse. And biofeedback can also be used to help with Raynaud's disease as well. We want to change our patient's diet and try and encourage them to eat smaller meals due to the tightening of the stomach. Make sure they're avoiding caffeine and caffeinated beverages. Due to the problems with reflux, they need to stay upright after they eat for at least 3 hours. Alcohol can make the symptoms of scleroderma worse. And it's also beneficial to elevate the head of the bed. And we need to make sure that our patients are actively doing range of motion activities. And if they are too tight to be able to do active range of motion, do passive range of motion to try and keep them moving to the best they can. So complications with nursing care of the patient with scleroderma. Some of the complications we run into is skin ulcers. They're not able to absorb the appropriate nutrients from their food. Esophageal adenocarcinoma, pulmonary hypertension, renal failure, heart failure, death, potentially. Nursing assessment needs to focus the physical assessment on skin ulcers, the thickening of the tissue and subcutaneous calcium deposits, and potential for a secondary infection. Joint examination, we need to be watching for flexion contractures. Pulmonary examination, we need to be checking for shortness of breath and wheezing. Examining the blood pressure, making sure that they aren't having hypertension. That leads a whole other set of comorbidities. Making sure they're eating appropriately, helping them with their support system and their coping strategies. This can be a very, very challenging disease to have. So we need to look at ways that we can help educate the patient about Raynaud's, and that we help the patients understand what they can do to reduce the pain that's associated with Raynaud's. So one way, making sure that you are dressed appropriately, as we've talked about. Make sure you keep that head covered, keep the trunk warm of the body, and decrease or discontinue tobacco use. Make sure you're using moisturizers on the skin daily. Avoid using very drying soaps and detergent. You may need to have extra protective padding on areas where the skin is likely to experience friction, like the elbows, to prevent more trauma from occurring to the skin. Check the skin to make sure that there is no cracking or signs of infection. And if so, you need to soak the ulcerations, apply topical antibiotics, and use occlusive dressings. Next condition we're going to look at is called Sjorgren Syndrome. With Sjorgren Syndrome, everything is dry, okay? So with Sjorgren Syndrome, this is a great graphic that will help you to remember exactly what's happening with Sjorgren Syndrome. This is a chronic inflammatory autoimmune process that affects just about all the glands in your body. It affects the lacrimal and the salivary glands. The disease can be primary or secondary. Primary, it happens and we're not real sure why. Secondary is in response to something else. So secondary Sjorgren syndrome is often seen in rheumatoid arthritis, but it can also be seen in lupus and in some other connective tissue diseases. Diagnostic criteria involves having 2 of 3 different things present. So they are looking at presence of antibodies towards the salivary glands and the lacrimal glands, something called an ocular staining score, because there's not enough fluid within the secretions from the eyes. So they will look at that. And then lymphocytic, looking at lymphocytes within the saliva. So as you can see, she's experiencing dry eyes, dry cough, dry mouth, joint pain, swelling, stiffness, and her salivary glands are swollen because it doesn't have enough fluid in them to be able to make saliva. The patient with Sjorgren syndrome. This is a chronic progressive autoimmune disease, and it's due to inflammation and dysfunction of the exocrine glands. Again, often it's associated with rheumatoid arthritis or other rheumatic diseases. How does Sjorgren syndrome happen? It's due to the exocrine glands being destroyed due to lymphocytes, and the immune system is attacking itself. It's thought to be influenced by several factors, including genetic disposition, immunology factors, different infections, and hormonal influences. It's thought that the antibodies are directed at the exocrine glands, and that causes disturbed function of the involved tissue. Sjorgren syndrome primarily affects middle-aged women. What do we see when we have Sjorgren syndrome? Ocular, we see xerothymia or dry eyes because of decreased tear production that leads to keratoconjunctivitis and photophobia lasting greater than 3 months. We have oral dryness, xerostomia, dry mouth, caused by this diminished production of saliva, also causes mucosal ulcers and stomatitis greater than 3 months. You need lots of fluid to be able to swallow food. You may also have recurrent or persistent salivary gland enlargement on one side or on both sides. Dryness of all mucous membranes, the nose, the skin, the mouth, the vagina can also occur. May see a rash, dysphagia, Raynaud's, as we've talked about previously, arthalgias, and myalgias. Finally, you can see some major organ dysfunctions, such as interstitial pneumatitis, inflammation of the lungs, glomerulonephritis, vasculitis, thyroid disease, and different forms of neuropathies can happen as well. Migraine can also be associated with Sjorgren syndrome. Not really sure what the mechanism is for that. We just know that it is associated. So when we have a patient that we suspect having Sjorgren syndrome, we need to do a diagnostic evaluation. And with our CBC, we often find mild anemia and leukopenia present in about 30% of the patients. ESR, the SED rate, is elevated in about 90% of the patients. Rheumatoid factor will be positive in about 75 to 90% of the patients. ANA is positive in 70% of the patients. Antibodies to different nuclear proteins will be present. You'll see specifically these are called SSA and SSB. SSA antibodies is called the Rho antibody, and those are positive in patients with Sjorgren syndrome and systemic lupus. SSB, the law antibody, is positive in patients with Sjorgren syndrome, also with patients who have SLE, systemic lupus as well. We may see organ-specific antibodies. The antibodies are directed against specific organ tissues. And we need to do x-rays of different joints to rule out erosive arthritis. The salivary gland may require a biopsy to be able to determine and confirm the diagnosis. It's usually done in one of the smaller salivary glands in the lower lip. How do we manage Sjorgren syndrome? Often we use NSAIDs and hydroxychloroquine to control symptoms. We may be using steroids to decrease the inflammation and cause immunosuppression. These patients, because their mouth is so dry and they lack the antibodies that will be living in the saliva, often these patients have to take antifungal agents because they end up with oral candidiasis. And so to get rid of this fungus, they are needing to take antifungal agents. So topical agents that can be used is going to be cyclosporin emulsion eye drops, and these help to reduce ocular inflammation and increase tear production. So we may be using other products to help improve salivation and keeping the mouth moist as well. We want to make sure we're doing very good oral care using toothpaste, mouthwash. Chewing gum is effective for some people to help them to be able to increase the saliva within their mouth. Basically, we end up treating the symptoms of dryness through different mechanisms, different medicines. We may be using artificial tears or lubricants. We may be using sugar-free liquids, gums, or candies, vaginal lubricants, making sure we have dental care frequently, doing good brushing your teeth and flossing, making sure we do fluoride treatments, avoiding high sugar, high salt foods. And at night, you may need to wear special occlusive goggles to help decrease the amount of drying that happens within the eyes. As the eyes get so dry, what will happen is people will end up with corneal ulcerations. They'll end up with vascular problems of the cornea, glaucoma, and can potentially have cataracts as well. The lack of saliva also is associated with increased dental caries, tooth loss. May also end up with concurrent lymphoma as a result of Sjorgren syndrome. So as we're doing our nursing assessment, we need to be sure to look at everything that should be moist that probably isn't in the patient with Sjorgren syndrome. They have the risk for impaired skin integrity. They also have the risk for sexual dysfunction as a result of the dryness, from the lack of vaginal secretions. We want to maintain the mucous membranes, make sure our patients are eating appropriately, and do some education about sexual functioning, making sure they're using water-soluble lubricants, suggesting specific positions to help decrease discomfort for the patient as well. Fibromyalgia. Fibromyalgia is a very common type of autoimmune disease. It's characterized by fatigue, diffuse muscle pain and stiffness, often have problems with sleep, and you have several tender points on physical examination. So the American College of Rheumatology has stated that fibromyalgia is not a rheumatic disease. Your patient with fibromyalgia. This is a very common syndrome. We're not really sure what causes it. It affects between 3 and 6 million Americans, and it's usually women between the ages of 29 and 37. Fibromyalgia most likely represents a complex pain syndrome in which there's an abnormality in central sensory processing, dysregulation of peripheral pain receptors, and psychoneuroendocrine dysfunction. So clinical features that it include a reduction in the pain threshold. So people with fibromyalgia report more pain than people without fibromyalgia. And their brain actually is sensitized to pain, so they have an increased physiologic response to pain. And they often have mild muscle contractions and tension that results in post-exertional muscle pain. Their muscle strength decreases because they're so tired, they're not really moving a lot. This muscle strength decreases and they end up very deconditioned. Manifestations of fibromyalgia, it's characterized as an achy chronic muscle pain, tightness or muscle spasm, sleep disturbances, headaches, painful menstrual periods, and problems with thinking and memory. So they end up being very tired all the time. And exacerbation of symptoms often happens due to stress, poor sleep, infection, and exertion. So with fibromyalgia, you end up with several tender points. A fibromyalgia diagnosis would be confirmed if you experience pain in at least 11 of the 18 tender points and had widespread pain in all 4 quadrants of the body for at least 3 months. Tends to be a diagnosis of exclusion. So to diagnose fibromyalgia, our goal is to rule out other disorders. Test results are generally normal in fibromyalgia. Complete history and physical exam. A sleep study needs to be done to rule out organic sleep disorders. Need to look at symptom management and making sure that the treatment is individualized and goal-oriented. You want to use non-opioid analgesics to relieve pain. NSAIDs and acetaminophen are rarely effective alone. Maybe giving these patients tramadol, and naltrexone has also been shown to relieve symptoms. Patients with fibromyalgia may also benefit from a low-dose tricyclic antidepressant to improve sleep quality and help control chronic pain and depression. Sleep medicines may be used for a while. People with fibromyalgia also frequently report restless leg syndrome that can interfere with sleep. Oops. Exercise is very important for the patient with fibromyalgia as well, so ensuring that they're staying moving. So nursing care. With this patient, you need to reassure that this disorder is not progressive, that it's already to the severity level that it's going to get, and it does not cause deformity. Complications will be deconditioning, work disability, inability to fulfill social roles. They have difficulty maintaining their different roles within the community. Pain level changes, so it needs to be frequently assessed. Need to assess functional ability. Frequently, these patients have problems with mood and depression, so their coping strategies need to be assessed, and the presence of a support system needs to be evaluated as well. Osteomyelitis. So this is an X-ray of osteomyelitis. You can see the growth in the bone. The right femur has been deformed as a result of the infection. Osteomyelitis is a severe pyogenic, which means fever-causing, infection of the bone and surrounding tissues that requires immediate treatment. Your patient with osteomyelitis may have it due to a penetrating wound, may have it due to bacteria within the blood, pre-existing infection, or vascular insufficiency. Unfortunately, often osteomyelitis is attributed to and associated with patients who are abusing drugs, because osteomyelitis, if they're shooting up drugs, the bacteria gets in the blood and it's a step away from getting into the bone. Once it does get into the bone, it's harder to be able to treat because most antibiotics do not cross the bone matrix. Pathophysiology of osteomyelitis. Enzymes, phagocytes within the body release enzymes that destroy the bone tissue. And in the place of this bone tissue, there's swelling that happens, vascular congestion, and also pus will take the place of the bone. Ischemia happens, the bone will start to die. And in hematogenous osteomyelitis, the pathogens are being carried in through the blood from other areas of infection. And frequently the spine can be at a site of infection. Osteomyelitis, if we are exposed to the blood of somebody who has osteomyelitis, it can infect us, and it's a contiguous infection. What that means is once it's in one bone, it will start to spread into other bones. The diagnosis may be difficult to make, and it may not be made until it becomes chronic. Osteomyelitis often happens in people with peripheral vascular disease and also diabetes. Acute osteomyelitis, its diagnosis is made based upon initial clinical signs. We'll be doing a CBC and see infection present within the body, and also our SED rate will come back positive. We'll be doing bone or blood cultures, aerobic and anaerobic blood cultures, and checking the SED rate. SED rate's elevated. Be looking for X-ray evidence of osteomyelitis. Usually we can't see it on X-ray until the patient has already been infected and bone remodeling has occurred for 14 days. MRI is being used much more frequently because it quickly can distinguish between soft tissue and bone marrow. So to treat this, we'll be giving the patient high-powered antibiotics through their IV, and full recovery is possible with minimal loss of function if it's an acute situation and we catch it early. Most cases of osteomyelitis are caused by Staphylococcus aureus. This is a type of bacteria that is normal within the flora of the skin. Surgical debridement. Sometimes we may have to go in and actually pull out some of the infectious material from inside the bone. And the way that we would do that is through a myocutaneous flap. Complications of osteomyelitis will be a non-healing wound, immobility, amputation. Nursing assessment includes getting a detailed history of the injury, what caused it. Be aware that systemic symptoms are often acute in children, but not so much with adults. So frequently these patients are going to be in acute pain. They're not able to move, and it's a very long-term process to be able to get rid of this infection. Septic arthritis. This is a perfect picture of a septic joint. So sometimes the bacteria doesn't go into the bone, it goes into the joint. So with septic arthritis, you can see the swelling and the redness, and that patient's left leg just looks really, really angry. So with that, we know that septic joints and septic arthritis stem from persistent bacteria in the blood, previous joint damage, problems with immunity. They often lose their skin integrity, and frequently it can be the result of a direct contamination of the joint. What that means is they had a joint injection and it ended up with an infection directly from that joint injection. Most common bacteria, gonorrhea bacteria, and also Staph aureus. The joint infection leads to inflammation, resulting in problems with the synovial fluid, and that creates an additional fluid being made within the joint that again contributes to swelling. Abscesses are when white blood cells are actually dying as a result of fighting this bacteria, and that's the reason that pus often has a white, yellowish, sometimes greenish color. The type of the color of the pus that's coming out of an abscess is related directly to the type of bacteria that's causing the abscess. And if this isn't fixed, the entire joint can be destroyed. You may have to have a new joint put in for patients with septic arthritis. A septic joint happens quickly, has joint pain, obviously, stiffness, redness, swelling, heat, tenderness, and you can have a systemic fever and be having chills as a result of a septic joint. So what do we do? Septic joint is a medical emergency. We've got to get this treated because the bacteria can go into the whole systemic circulation and make your patient septic. So with this, we need to pull some fluid from the joint and do a gram staining culture. Now, I have seen some septic knees that were absolutely swollen, size of a basketball. When the physician got in there and pulled the fluid should be like a straw colored fluid that's viscous. It can be poured. And this patient's knee was just so messed up that it actually was a thick white substance that they pulled out of the knee. And you could tell just from looking at it, it was completely cloudy. So you can tell the presence of bacteria in it. What do we do to fix it? We pull off some of the extra fluid, doing joint aspirations. In some situations, we may completely drain the infected joint, and we want to use rest, immobilization, ice, elevation, antibiotics, and a septic joint will require the patient to engage in physical therapy. We may want to use ACE bandages and other compression and continue the patient moving, but otherwise the other muscles will start to deteriorate. Bone tumors. So we have several different types of bone tumors. The benign bone tumors are in yellow. This is an osteochondroma, an endochondroma, an osteoma. And malignant bone tumors have the red dot, osteosarcoma and Ewing sarcoma. And so we're not going to be asking you to specifically know which individual type is what, but you will need to know that they can be malignant or that they can be benign, and that the worst is osteosarcoma. How does this happen? To increase risk factors that contribute to bone tumors is going to be increased growth of the bone, increased bone activity. Those signals that tell the bone to stop growing and stop adding tissue, for some reason, get turned off. And so the bone just continues to grow and just do whatever it wants. Often, these signals are turned off due to exposure to radiation. Patients with bone tumors, the tumor takes away the area where the bone marrow is, so they may often need bone marrow transplants as well. Now, these bone tumors cause weakening within the bone, so it makes complete sense that we will end up with fractures in bones that are affected by tumors. Now, malignant tumors, these are our invaders. They're going to go in, invade, and destroy other bone tissue. So manifestations of a bone tumor, bone pain. It is an awful type of pain. You may see a mass on x-ray. You may be able to feel a mass, an impaired function of that bone. Our goals are to have a prompt diagnosis, be able to get that tumor out. Sometimes we can, sometimes we can't. We also want to prevent complications and educate the patient. To diagnose a bone tumor, we'll be doing a biopsy, looking at x-ray, CT, MRI results. Also, specifically, we'll look at the alkaline phosphatase and calcium levels within the body as well. How do we treat a bone tumor? Chemotherapy, radiation are the big ways. We may have to amputate the limb where the tumor is. Ideally, we do this prior to the malignant bone tumor metastasizing to other bones. Patient is at risk for chronic pain. They may lose their ability to walk for physical mobility, take care of themselves. And with bone tumors, it's a very, very painful painful condition for the patient to have. Okay, as always, if you have any questions, let me know. Thank you. Bye.